Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome. This is Richard Hazel, and today I'm going to talk about a new patient I saw this week. He plays golf. He's about 50 years old, and 10 years ago he had a meniscus repair surgery in his right knee, and now for the past year he has developed a lot of medial knee pain and posterior knee pain, and says that when he plays golf, by the time he's finishing his game, he can't walk with his toes pointing forward. After walking around a lot, his leg starts to turn in, and he has more pain. So he might start out walking around playing golf without knee pain, and by the time he's finished, he has a lot of posterior and medial knee pain, and his foot can't stay pointed forward. And I don't know if that's because of pain or if it's actually pointing in that direction regardless. But anyway, so he showed me where the pain was, and it looked like pes anserine where he was touching. And I'm thinking popliteus as well because of the posterior pain. So upon discussion, I said, do you have any noticeable hip issues? And he said no. So I am thinking in my head, the pain is likely coming from popliteus and pes anserine muscles that are internally rotating the tibia. So I don't know if I've explained it before, but tibial rotation happens especially when the knee is bent. The pes anserine muscles can internally rotate the tibia, and the lateral muscles that attach to the IT band and the vastus lateralis can externally rotate the tibia when the knee is not locked straight. The popliteus unlocks the knee. So if you're standing with your knees locked and then you need to bend the knee, unlock the knee, the popliteus assists in that. Some people with popliteus pain will feel pain behind the knee when they scoot forward in a chair. So if you're sitting at your desk and you want to scoot your chair under the desk, you put your heels out, or you straighten your legs and you dig your heels into the floor and you scoot your chair forward, and that uses popliteus, which can cause pain if your popliteus is injured. So, and injured means short and tight. It doesn't mean any kind of acute injury. I mean, it's an overuse injury of shortening of the muscle. So, of course, I palpated popliteus, and he does have soreness there. But then I'm really interested in the pes anserine. So we did a hamstring length test on the good side, and he went to 90 degrees of hip flexion. Very good. Much better than what I could do. And on the affected side, the right side, he got to closer to somewhere around 50 degrees of hip flexion, not 90. So we know the hamstrings are tight, and the medial, that semitendinosus hamstring on the medial part of the hamstrings is part of that pes anserine connection. You've got semitendinosus, you've got the sartorius and gracilis. So I'm looking at gracilis next, and it's obviously tighter than the other side. I can see it without even testing. I can tell that his right gracilis is tighter than the left. And I palpate, and we did a little bit of adductor length testing I want to show him what's going on. So, and it was noticeable shortening of the gracilis on the right side. And then I'm thinking about if the knee is being internally rotated, if the tibia is being pulled into internal rotation when he walks, and the gracilis is pulling the knee and causing that medial knee pain from the pes anserine muscles, then the compensation has to come from the lateral side. So you have to have some IT band tension to try to keep the knee pointing forward. So there's going to be some hip stuff going on there. So I check his external rotators, internal rotators. I do the normal passive internal rotation, external rotation on the good side. His external rotation on his left side, his good side, is excellent. His internal rotation, though, was not quite 45 degrees. So I know his normal's a little tight, but on the affected side, he had restricted external rotation as well as almost zero internal rotation of the hip. So we know his deep rotators are super tight. And that's part of that correction for the internal rotation of the tibia. His hip external rotators are working hard to keep his whole knee pointing forward. And then, of course, the IT band muscles I have to test. So I test his good side, and he has very good strength on gluteus medius, gluteus minimus, and TFL. Then I put him on his other side, and I test the affected side, the right side, and everything was weak. And he was really kind of surprised because he had not been aware of how much less stable his right hip is. But his lateral stabilization is definitely affected. And I think that's a compensation for the internal rotation from the knee. I think all of this started post-surgically, and he did his rehab and everything, and he was pain-free for years. But as age and exercise kind of built up, he hit the tipping point where he's starting to have pain. So I treated the gluteus medius, minimus, TFL, piriformis, hamstrings, gastrocs, because gastrocs bend the knee as well. So I'm thinking functionally, there's no harm done helping the knee bend. So gastrocs and popliteus. I put 2 needles into popliteus. The popliteus runs at an angle. The upper part is attached to the outer part of the femur, and then the lower part is attached to the inner part of the tibia. And that's how it's going to internally rotate the tibia. So the needle goes very just medially, what should I say, laterally? It goes, lateral to the medial tendons of the hamstring. So that you find the tendon insertions for the semitendinosus membranosus. And so if it's on his right leg, you just go to the right of that, and you're going to be in the area for the popliteus motor point. And if you go too deep, you might get too close to the tibial nerve, and then his whole foot with the electric stim, his whole foot will dorsiflex. I didn't go that deep. I tried to stay right where I could see movement without any sort of nerve stimulation. And then I put another needle next to it, very close to the middle of the whole popliteal fossa, probably what would be close to a bladder 40, but not deep, because again, if you go deep, you're going to hit the tibial nerve. And I didn't want to do that. I wanted to put some electric stim on the muscle, loosen it up, and that's it. So I got the popliteus, the gastrocs, the hamstrings, glute med, piriformis, and then on his side I did glute min, TFL, got those loosened up. Then face up, I treated his quads and his gracilis that was super tight. So 4 more points face up. So it was 3 positions: face down, side lying, and face up. And then I had him walk around, and then the one thing he knew he could not do without pain was to kneel and to sit back on his heels like for a yoga child's pose. So I asked him if he would mind trying it, and he was a little nervous because it's going to hurt, and it didn't hurt, and he was so surprised. And he was really surprised at just how unstable his hip had been without him even realizing it. So on a first visit, I tend to treat the pain and not worry as much about the holistic picture of core stabilization and the other side flexibility, because if someone's not had any kind of acupuncture, I really want to keep the needles to the absolute number necessary for their pain without going overboard. So I said, when I see you next week, if you still have pain, of course, we're going to adjust the treatment. I may do the same thing and may do something else. If you do not have pain, I still recommend you come in, because let's treat both sides. Your internal hip rotation on your good side is not optimal. And I really think we can improve both sides mobility wise for your golf. And let's start thinking about other things that we can do that will improve your golf swing. And he's on board for that. He handled the needles very well. It was not a problem. So I was happy with that treatment. It was fun to unravel and to kind of see how the body was compensating for that tibial internal rotation caused by the popliteus. And it's probably because of the surgery. He said it was the posterior part of the meniscus that they repaired. My guess is those muscles had gotten tight as a compensation before surgery. Then after surgery, he was functioning much better, and it took time to accumulate enough muscle tension to start having pain. But anyway, it's an interesting case, and I don't think I've talked a lot about posterior knee pain, and I thought that was a good chance to discuss some things you might see for posterior knee pain. So that's it for today, and I hope you're having a great weekend, and I will talk to you soon.